again, talking a little bit about an algorithm that we have come up with at the University of Iowa to help triage orbital fractures a little bit better. This work was previously presented at ASOPers this last year as well as AAO. These are the financial disclosures, nothing to do with this topic. So as you know, orbital fracture could be associated with severe ocular and periocular injury that might require emergent management. So, you know, as a institution with a very large catchment area, it's hard to figure out which one of those cases need to be transferred to us for that management. So currently there's not really a great standard to identify who that is that would most benefit from that transfer. And even though there have been a couple of other studies and algorithms proposed, there's a wide range of specificities as well as none of them have really been prospectively applied to see whether or not they work. So really this was born of needing to identify high-risk cases that needed a higher level of care and expert evaluation. So that's where this came from. We really wanted to develop a new fracture algorithm to help identify those patients and retrospectively evaluate these other algorithms and see how they compare to ours. And then also for our own benefit, we kind of wanted to see, you know, where were these cases coming from and evaluate what kind of travel burden these patients underwent. So we did a retrospective chart review, we recorded data, we developed the algorithm, and then we retrospectively applied the other algorithms as well as ours, and then there's a cool little map of travel paths in the state of Iowa for these cases. So what we found is we just looked at all of the ophthalmology emergency room consults in 2019. There's almost 1,000 of those, and about 150 were for orbital fractures specifically. And then we further narrowed down to a total of 134 cases, primary ED consults for patients with orbital fracture. It was mostly male, average age was about 50. The mechanisms of injury you see there, falls, assaults, bicycle or motor vehicle crashes were the most common. Of those 134 patients, only 19 of them actually identified with emergent ocular and or periocular injuries. Some of the ones that we considered emergent or urgent, orbital compartment syndrome was the most common, open globes, muscle entrapment, rupture, thermal injuries, and then of note, we actually didn't identify any retinal detachments in this cohort. So as far as the algorithm development, it was, you know, a logistic regression model was created. And we actually created two models, one called HOPE and then one called HOPE CT, and I'll go into that a little bit there next. The factors that we took into play in developing the algorithm included things like age and gender, whether the injury occurred with a foreign body, what day of the week the injury occurred, the mechanism of injury, other things like fracture locations or type of fracture, eyelid laceration, you know, visual acuity, you know, eye exam type of findings, motility findings, RAPD findings. This all went into the original HOPE algorithm that we developed, and then the second one, the HOPE CT, we actually included CT interpretation by an ophthalmology professional. So CT evidence of an open globe injury, things like sort of flattened globed or intravitreal hemorrhage, retrobulbar hemorrhages, and then extraocular entrapment by CT. And that's, you know, a little bit controversial, I think, right? Because we always say extraocular muscle entrapment is really a clinical diagnosis. Which is why a lot of times you see the CT reads by the radiologist that say, you know, displaced fracture, possible muscle entrapment, clinical correlation recommended, right? So a radiologist called both of these images possibly entrapped. The top image by ophthalmology read, there was less concern for entrapment, right? We have a nice straight inferior rectus muscle on that sagittal view, as compared to the picture on the bottom where you clearly see that tenting, that inferior rectus muscle being pulled down into the fracture. And so for that one, that would be a true muscle entrapment as per ophthalmology read, whereas the upper one, not so much. And so I think this was a difference in the algorithm. Here are the numbers of all of the, you know, that were run with all of the different variables. And essentially, for the HOPE, things like age, mechanism of injury, foreign body, all of those were factors that kind of popped up as important in trying to figure out whether or not there was going to be a concurrent, you know, severe emergent injury occurring with these fractures. With HOPE CT, you can see it's actually really narrowed down. You can see in bold are the ones that are common to both of them. But with the addition of the ophthalmology overread of the CT imaging, it really sort of limited the other factors that became important in determining whether or not there's going to be a concurrent severe emergent injury that occurred with this fracture. So we took the HOPE and HOPE CT and actually compared them to a couple of existing algorithms that were out there in the literature. One of them came from the University of Texas, and I think I just wanted to draw your attention to the fact that it says cooperative patient. Right, predictors of severity, blurred vision, pain, those are sorts of things that need a cooperative patient ideally to assess. This algorithm did have a pretty good sensitivity and specificity, however, but I think was limited by the cooperative patient portion of things. South Texas had an algorithm that was mainly aimed at trying to reduce the number of ophthalmology consultations that were occurring. They also, you can see, incorporated radiographic overreads into their algorithm, and they found that it reduced the consult rate, at least emergently in the emergency room, by 50%, and they ended up only needing to intervene, 20 to 35% of their cases. Massachusetts Eye and Ear also had an algorithm that sort of had a bedside exam component to things. They applied it to about 100 eyes. Had a really good sensitivity, but not so great of a specificity for emergent ocular injuries in the setting of fractures. So when we took our cohort from 2019 and ran the numbers with the other algorithms compared to ours, the HOPE CT seemed to do the best, right? Very sensitive, very specific, had a good positive predictive value as well as negative predictive value. So we were pretty excited about that. And this is a picture of like why we sort of did this in the first place, right? So University of Iowa sits in the middle of a really large sort of landmass area. We get a lot of transfers in. You can see the little scatter plot there of where everybody came from. And in general, almost everybody had at least 2 stops total, meaning they came from some other institution before they were transferred to us. And on average, they traveled about 87 miles or 140 kilometers to get to us. Some patients traveling over 320 kilometers to get to us, which is a long way, and a lot of these patients don't have the means necessarily to afford that kind of transportation. And then what happens when they get to us, right? They get to us, and then how do they get home from those ways? So, and this I think is the real kicker. Transfers from outside facilities was the biggest reason for these fracture kind of transfers. And if you look down there at the bottom right, like, over half of the patients that we evaluated ended up being discharged without further intervention, right? So we sort of felt like we could do a better job of figuring out who needs to come for further evaluation emergently. And we think that the HOPE CT protocol is something that we can use that will help reduce unnecessary transfers, hopefully lower costs for our patients, improve the distribution of the resources that we do have, and of course promote safe, accurate orbital fracture triage, because certainly we don't want to miss any kind of emergent condition that needs repair. Obviously, there's limitations to this. Small sample size, it is retrospective at right now. It includes some patients sent for other trauma, and I think the biggest thing is it does require the availability of CT imaging and an ophthalmology overread. An ophthalmology overread by somebody that's been trained at least to be able to do it, so I think that would be one limitation in it. But I think we have something here. We're actually actively continuing to work on it. So we're currently applying the algorithm to a larger cohort of patients that were not using the original algorithm, and then we're going to refine it, test it again, and then prospectively test it, and hopefully with the goal of developing an online tool that we can just share on the iRounds website so the public can use it and use it to help triage fractures that are coming their way. So that's all I got. Those are some of the references for the other algorithms that I talked about. That's my team that helped put this all together. And I just wanted to mention, I was going to give a talk on hearing dysfunction in teprotumumab, but in the interest of time, I decided not to. I'm happy to talk to anybody about the University of Iowa experience in hearing loss with the use of teprotumumab. We actually just published in the ophthalmology journal